All right, so everyone, my name is Colin. I'm doing the disaster medicine lecture. So just obligatory thanks to the disaster team. So I want everyone to imagine you wake up, you're on nights, it's snowing outside, heavy snowfall, a storm is coming. You're expecting a foot of snowfall. It's going to be 10 degrees Fahrenheit overnight, and you wonder if you can even make it to work. You open your phone, you've got an email from Dukas warning you of extreme cold weather, and you need to prepare for accidental hypothermia, cold exposure injuries, an influx of patients seeking refuge. So lying in bed, you ask yourself, where do we as physicians fit into this coordinated response to climatological disasters like this? Or what will I do if critical hypothermic patients come into CCT tonight? Or is it just me, or are these storms becoming more severe? So my talk's going to be about winter storms and accidental hypothermia. We're going to talk about the rising nationwide incidence or the increasing severity of these storms, the components of the disaster cycle, mitigation and preventative strategies for extreme cold weather events, and the pathophys management of accidental hypothermia. So winter storms have been increasing in frequency and intensity since the 1950s in mid and high latitude areas per the globalchange.gov database. Some studies are starting to link climate change and the warming Arctic to extreme winter weather events that we've been seeing in the US. So this helps to begin to explain the extreme weather we've seen, like in the Deep South last month, where there was record snowfall throughout the Gulf Coast. So as we finish residency, a lot of us are going to spread out, move to different cities, many of them not as prepared for these increasing and more severe winter storms that we'll face. So it'll be up to us to treat the patients that come in after these storms hit us. And in order to best do so, it's important we understand the systems with which we respond to disasters. So disaster management can be summarized with the disaster cycle. We've seen this before. It consists of 4 key components: mitigation, preparedness, response, and recovery. I'll talk about it more as we go through the lecture, but broadly, this is proactive steps towards reducing disaster impacts before an event occurs, preparing for potential disasters, actively managing the event during its occurrence, and rebuilding and restoring affected areas afterwards. So the remainder of the lecture will talk about winter storms in the context of the disaster cycle. So the mitigation of winter storms includes steps such as winterization of the home, including regulations that require carbon monoxide detectors, winterizing your vehicle, and the development and maintenance of organizations that serve populations most vulnerable to these extreme weather events. Preparedness, on the other hand, focuses on developing plans, procedures, and resources to ensure an effective and coordinated response, such as early warning systems coordinated by local governments, development of protocols to aid the unhoused during winter storms, and training of physicians on basic disaster response principles. So the response phase focuses on taking action to save lives, reduce health impacts, and ensure public safety. So first, I want to talk a bit about the responses to protect unsheltered people from extreme cold weather, and then I'll talk more about how we can be prepared to treat patients with accidental hypothermia during these types of storms. So Code Blue is a New York City initiative aimed to protect unsheltered people from life-threatening winter climates. So basically, this is something that is activated whenever temps drop below 32 between 4 p.m. and 8 a.m. This includes wind chill, and if there's any freezing rain or sleet, it'll also be activated. And during this, shelters relax admission rules, meaning anyone who needs a warm place to stay can go in without the normal intake process. Additionally, there's outreach teams that patrol 24/7 during these periods that actively engage with individuals experiencing homelessness, offering transportation to shelters, warming centers, and they're also available. If you see anyone on the street that you think is at risk, you can call 311 and an outreach team will come to them. So additionally, on Code Blue nights, there are service buses stationed throughout the city that can serve as temporary respite for unsheltered individuals or just for anyone seeking warmth. Staff are available on site to engage the individuals and to provide additional info. So this is any Code Blue. There's actually one station outside of Kings County, which I only recently learned about. This is from social work. They penciled it in. So you can ask them if you're concerned for your patient, if it's like 20 degrees out, you can go to social work, ask them what resources are available through Code Blue, or if we do have the bus outside. You can also just have your patient stay overnight if there's space and it's not blowing up. So the next is if our patients are already exposed to the cold and they're coming in, what are we going to do? So there's different injuries that we could expect with winter storms. This is going to include accidental hypothermia, which will be the bulk of this talk, frostbite, carbon monoxide poisoning, overexertion injuries, and trauma. So So what we're talking about. So first, let's talk a little bit about the physics of heat loss. So we lose heat in four primary ways: convection, conduction, evaporation, radiation. Conduction is heat transfer when a cold body is in physical contact with a warm body, and the warm body transfers heat to the cold body. Convection is when a liquid, like a gas, like air or water, passes over a warm body and it pulls the heat from it. Evaporation is when water evaporates and in the process absorbs heat. And then radiation is when heat is emitted in the form of infrared waves. So practically the way we kind of address heat loss is to just minimize all of these ways that heat is lost. So it's warming the room, removing wet clothes, drying the patient, providing insulation, protecting them from wind, etc. So I'll talk a little bit about physiology of cold. First, we can expect certain hemodynamic changes in the patients that are hypothermic. Initially, they will have peripheral vasoconstriction, an initial increase in heart rate, but as they get progressively colder, they'll become more bradycardic and hypotensive. Additionally, at low core body temperatures, individuals will experience increased myocardial irritability, which some believe is what leads to what we call rescue collapse. This is when a patient who is hypothermic but otherwise stable is moved and they suddenly arrest, believed possibly to be due to some dysrhythmia because of this myocardial irritability. So these patients, it's important to be careful with them, keep them horizontal, don't jerk them around. The respiratory responses to extreme hypothermia initially include tachypnea and then a progressive decrease in minute ventilation and eventual respiratory arrest. And it's important to know that as you resuscitate these patients, many of them will develop pulmonary edema. There's also a range of neurologic responses that these patients will experience. The symptoms that they might present with is broad. It could just be poor judgment, amnesia, dysarthria, ataxia, apathy, unconsciousness, areflexia, or EEG arrest. And approximately below 29 degrees, or rather I'll say at lower temps, brainstem function can be impaired and your testing of brainstem reflexes is not as useful. So below 29 degrees, pupils can become fixed and dilated, and below approximately 23 degrees Celsius, corneal reflexes may be absent. So neither of these is a reliable neuroprognostic test. There's also the concept of paradoxical undressing. So as patients get very cold, a late sign of severe hypothermia is paradoxical undressing, in which patients remove their clothes, believed to be some response to changes in vasodilation. They'll also engage in what's called terminal burrowing, which is seeking out small closed spaces or digging holes in the ground to die, basically. So in a survey of 207 fatal hypothermia cases in Sweden's 4 northernmost counties, some degree of paradoxical undressing was seen in 30% of patients. Other physiologic responses to touch on briefly are cold diuresis, which can lead to significant fluid losses, rhabdo, pseudo-rigor mortis, coagulopathy, which will present similarly to DIC and has a similar mechanism, and then decreased cellular oxygen consumption, which actually ends up being protective against ischemia. So our initial evaluation, before we start doing it, just to reiterate, core measures, ABCs, IVO2 monitor if the patient's sick. Then you want to get a core temp. One thing to know is we have the rectal probes we use. Make sure that it's actually capable of going below 34 degrees. I haven't checked. A lot of them aren't. So you need a special probe that can handle extreme measurements. If the patient's intubated, an esophageal probe is ideal and preferred because it's closer to the heart. It better estimates the heart's temperature. Otherwise, you can also use rectal or bladder probes. You want to get a potassium level. Levels greater than 10 or 12 are not compatible with life, and you could just terminate your resuscitation at that time. Coagulopathy, just a note, if you send off coags, although we expect a coagulopathy, the levels might be normal because they're going to warm the blood in the lab, and then it's going to restore their function. And then the last thing is you'll be evaluating for secondary causes if there's any uncertainty about why the patient is cold. So just doing tests to assess for hypoglycemia, sepsis, trauma, endocrine, etc. You also want to get an ECG. We classically see Osborne waves, which is on tests. It's a positive deflection seen at the J point of precordial and true limb leads, but it's seen in other pathologies as well. You'll probably see a lot of shivering artifact as well. This is mild. It can be more pronounced. And then you can see another host of dysrhythmias, such as bradyarrhythmias. You can also see prolonged intervals and PVCs. So general management. So It's important to safely and carefully handle these patients. Again, you want to avoid rescue collapse. You want to avoid precipitating some dysrhythmia. Consider early airway intervention if needed. These patients can come in unresponsive, pulseless. They may need to be intubated. Just know that they're likely in a low flow state at these temperatures, and your RSI meds are not going to take effect as quickly. Consider IV fluids. With the cold diuresis, they're likely volume down. They may be in rhabdo, needing fluids. Just know that we have a fluid warmer at County. Use the warm fluids. And then for dysrhythmias, just briefly, I mean, typically you just need to warm them up. If you need to support their pressure, start CPR, you do that, but just warm them up. Antidysrhythmics are typically unpredictable in their response in these patients. And then other meds you can just give based on suspected secondary causes of hypothermia, antibiotics, levothyroxine, whatever it may be. So I'll talk more about rewarming. So Tintinelli's has a really good chart kind of breaking up the stages of hypothermia based on symptoms and degree of, or the level of core temp, and then how you should rewarm those patients. I'd reference this if you guys are in the ED, you can just get it through Downstate Library. But just for our purposes, this is kind of a dumbed down version from WikiM. So I'll go through each stage and kind of the type of rewarming we would expect with that. For the mild patients who are 35 to 32 degrees Celsius, typically awake, alert, not in extremis, they don't need anything except for passive external measures. So preventing additional heat loss by having them in a warm room, removing their wet clothes, putting on warm blankets, hypothermia cap, just things like this. For the patients that are moderate, this is patients that may be a little more confused. Their temps are 32 to 28 Celsius typically. Heating blankets, radiant heat, warmed air, which is how the bear huggers work. And you can also give warm humidified air via the face mask or through the ET tube. And then for the severe patients who are typically less than 28 degrees Celsius, although they can be a bit higher, but they're confused or unconscious, they do have pulses. These are the patients that you do active internal rewarming. So this would be things like heated IV fluids, bladder lavage, which is just placing a Foley, pumping in warm water, and then flushing it out and repeating. You can also do thoracic lavage. This is placement of 2 chest tubes, one anteriorly at the midclavicular line, 2nd, 3rd intercostal, and one at the posterior axillary line, like 4th, 5th. And you're pumping warm fluids through the anterior tube and draining it out into a continuous drainage receptacle through the posterior tube. You could also do peritoneal lavage. I'm not going to talk much about that here. And then something I want to talk more about is ECMO, which I think is something that we could consider doing if we have these patients. So the rationale for this, usually VA ECMO would be used for hypothermia rewarming. You're going to support their circulation while you rewarm them. So this, they may need 5 to 6 hours of CPR. This would mitigate the need for compressions. Also, the system itself has a built-in warmer, so you can just run warm fluids through. Additionally, these patients, they would be good candidates for ECMO because they can tolerate 5, 6, up to 5 hours of CPR or ECMO. Because cooled, they have good neurologic recoveries, potentially full neurologic recoveries. Hypothermia is itself protective against, it is neuroprotective. And then it's been studied and there are improved outcomes with ECMO. Per Tintinelli's, they talked about the number needed to treat being 2 to prevent death in the right patient group. Typically, survival rates in well-selected patients that are treated at an ECLS center is 50 to 100% versus 10 to 30 if treated without extracorporeal warming. So when is it indicated? For arrest patients, you just first want to make sure there's no other obvious sign of arrest. So a good example is the patient who was buried in an avalanche for 35 minutes, or someone who drowned first and then cooled, or someone who died of a traumatic incident and then cooled after dying outside. These patients won't have good recoveries. You don't want to use ECMO for them. Also, if they're already warmer than 32 degrees Celsius, they're not a candidate for ECMO. They should already have regained pulses at this point. And if the K is greater than 12, there's never been a documented case of survival at those levels. Tintinelli's also talked a little bit about peri-arrest patients being good candidates for VA ECMO. They mentioned patients that fail to improve with external rewarming and minimally invasive measures, patients with life-threatening dysrhythmias, hypotensive patients, patients in respiratory failure, or patients with refractory acidosis. There's some evidence that the patients that are not in arrest don't really benefit. So in the ICE crash study that was in Japan, it was multi-center perspective, observational, not randomized. They found that the survival rates were pretty much the same in patients who got ECMO versus who didn't. But in the subgroup analysis of patients who had cardiac arrest and ECMO, 28-day survival was 58% in the ECMO group and 21% in the non-ECMO group. Additionally, the patients had significantly better neurologic recoveries in the ECMO group. So if you're trying to decide if the patient is going to be a good candidate for ECMO, there actually is a validated scoring tool that can determine the percentage survival prediction for this patient. It's called the HOPE score. If you're going to call the transfer center or talk to your ICU attendings about potentially transferring the patient out, it's just another piece of evidence to have for that discussion. So that aside, now we're warming our patient. Just one thing to remember, and any hypothermia lecture is going to talk about this, but we just have to know about the after drop. Basically, patients that are being warmed, they're initially very peripherally vasoconstricted. As you warm them, they're going to vasodilate, and a lot of the cold blood from the extremities is going to flush back into the core, causing a drop in core temperature. This is to be expected, just it's not something to freak out about. And then I just wanted to end with a few comments about CPR. For your pulse check, just know that these patients, even if they have pulses, are going to be in a very low flow state. May be difficult to feel. Take your time to determine that there's a pulse or not, because if you start CPR on someone who has a pulse, they're at higher risk of precipitating a dysrhythmia. Additionally, ACLS is modified for these patients, so there's something to know. There's controversy about the use of epi and defibrillation. The European Resuscitation Council and the American Heart Association have different opinions about what to do. There's some concern that these interventions could be ineffective or even dangerous. So tensionality is just recommended using standard cardiac life support protocols for up to 3 cycles. So giving epi 3 times, shocking 3 times is indicated. But deferring further defib and epinephrine until the patient's core temperature has increased significantly or their clinical status had changed. In terms of termination of CPR, we've all heard no one's dead until they're warm and dead. You want to at least heat them to 32 degrees before you call the resuscitation. And, if you're likely going to be doing CPR for a long time if they're not transferred out. So you'll send labs. If the K is greater than 12, you can terminate there because that's not a survivable level. So your shift ends, the sun's coming up the next day, you leave, storm's over, but the work's not done yet. The last stage of the disaster cycle is recovery. So for a lot of natural disasters, this is actually where we see the most morbidity. You think of your patients with chronic diseases, CHF, COPD, having exacerbations, they don't have access to their medications, they can't get to their appointments, they can't get to the ED. So it just makes it more important the act of cleaning up, restoring utilities, maintaining community support, and economic recovery that comes with these events. So in summary, we talked about winter storms, they're becoming more severe. We talked about the resources for unsheltered patients during these storms, the general management of hypothermia, and I want everyone to consider ECMO and accidental hypothermia patients if they meet these criteria. So these are my sources.